Thank you, John, for your kind introduction, and thank you to the organisers for inviting me to this really excellent conference. So we've had a few questions about liquid biopsies, so perhaps some of my talk will address some of those questions that have come up. I'm really going to present our access programme, so liquid biopsies for potentially faster diagnosis in pancreatic and biliary tract cancer. And we've grouped them together because they go through a very similar diagnostic pathway. So there are my disclosures. So we focus really on these two disease areas, partly because I treat them, but also in the world of all cancers, we think they represent the most highest unmet need in terms of innovation and need for both diagnostic improvements and therapeutic improvements. If we take pancreatic cancer, sorry, I don't have the published data for biliary tract cancer, we see some of the worst outcomes with the least progress in, over a decade. Obviously, biliary tract cancer, we do see now more therapeutic progress. But concerningly, globally, our outcomes are often at the bottom of the rankings. And also concerningly, we see regional variation. And so these, to my mind, really need to be tackled very urgently for both diseases. So where will we make the greatest impact? Well, I think the three areas all need attention. Clearly, earlier detection of asymptomatic people, faster diagnosis of symptomatic people, and really a revolution in treatment. And we're starting to see aspects of that in biliary tract cancer. So really, I'm focusing on faster diagnosis. It's not to neglect the absolute importance of early detection. I think all of these areas need attention, but faster diagnosis has been an area of our focus. There's faster diagnosis in primary care. There's also faster diagnosis in the secondary care route, and that's where I'm going to focus today. Again, it's not to neglect the others. I think all need attention, but this is one aspect. So we know that we aren't doing so well. In upper GI cancers, again, this doesn't separate OG, pancreatic, biliary tract. But in terms of the national cancer targets, and there are criticisms around those targets, but in terms of the faster diagnostic standard, in terms of the 62-day wait, we are nationally, and in my Cancer Alliance, also locally, consistently below the advised standard. So 75% of people being from a suspected cancer to being diagnosed, the faster diagnostic standard within 28 days. And that has a multitude of adverse consequences for the patients and the families that I've set out there, not least poor patient experience and worse outcomes. People can deteriorate during a protracted diagnostic pathway, and that really forms the basis, I think, for really strong patient advocacy, both AMMF and Pancreatic Cancer UK demanding faster diagnosis. And when, as a prelude to our work, when we did a focus group with a range of patients, we heard really very strong patient testimonials about this experience and about the need for urgent improvements. So what are some of the reasons that secondary care diagnosis, a patient is referred in either by the 2-week wait, cancer pathway, or by in-hospital presentation? Actually, in these diseases, 50% of patients come through the emergency route. And I think the major issue, it's a complex pathway because these are, coming to the point made earlier, cancers are located deep within the body. There's a difficult and complex invasive diagnostic pathway. And so I'm sorry to maybe this is a gross simplification, but we think about a quarter of the patients struggle to even get into the pathway, potentially because of patient factors, comorbidities, or recent infection. Biliary sepsis is a common presenting feature. A quarter, in some national audit data, maybe it's 1 in 5, maybe it's 1 in 4, patients have inconclusive biopsies. And again, we've heard about that, and loop through this pathway again. And Going through this pathway is multi-step because of the nature of the diagnostic workup with invasive tests and trafficking of tissue to pathology. And pathology, the services are under more duress than ever before. So whilst there's this idealised 62-day wait target, one can see why this is often significantly more delayed than that. So do liquid biopsies, a new recent innovation, offer any sort of solution? So what are liquid biopsies? So cells in the body, normal cells, can secrete their DNA into the bloodstream, and we can detect that. But cancer cells can also secrete their DNA into the blood circulation for various reasons. And we now have the ability, because of huge advances in next generation sequencing, as we've heard, to actually find and detect and measure molecular abnormalities within that tumour DNA through next generation sequencing. And again, the costs of that have reduced markedly. In pancreatic and biliary tract cancer, probably 80 to 85% of patients shed their DNA into the bloodstream, particularly with metastatic disease, stage 4 disease. Lower, maybe more like 50 to 60% in more localized disease. And so this really represents an opportunity to embed liquid biopsies in the pathway. So my group, or myself, I've been involved in a lot of research and trials in liquid biopsies after surgery for bowel cancer, and liquid biopsies in the advanced disease setting. But I've now recently started projects in the diagnostic space. And why did I do that? Well, it was really the COVID pandemic that precipitated that into 2020, when diagnostic capacity across the world, but very markedly in the UK, fell off a cliff. And then re-established, but at a limited capacity. And we were faced with the really shocking scenario of not being able to take a patient who was highly suspected with pancreatic or biliary tract cancer through the diagnostic pathway. So in my institution, we launched very rapidly under the COVID research banner with the HRA, a pilot study to deploy liquid biopsies to support a patient's diagnosis and access to treatment. We used an assay developed by our genomic laboratory hub that had already been validated in paediatric cancer that covered many of the targets that we look for, perhaps not all, but it was already validated. So we deployed that in various cohorts, not just pancreatic and biliary tract cancer, other cancers reliant on invasive diagnostics. And I think what we were struck by were a couple of things. The detection rate was pretty high, sort of coming up to 70% for both tumour types. And the specificity and the sensitivity were also very high. And again, don't forget, these are patients with scans highly suspected of biliary tract cancer. The other thing I think we learned was that you have to create an entire infrastructure around it. It's not as simple as just have a blood test. You have to create an infrastructure, and in terms of interpreting the results, again, coming to points made earlier, you need the buy-in and support of a molecular tumour board, because this was a new area. It wasn't sequencing to simply identify targets for drug treatment. Obviously, that's an offshoot and a benefit of this approach. But it was about, do we have confidence in this result to support a diagnosis of biliary tract cancer? So we learnt a lot from this pilot study. You don't need to, this is very busy, that sort of shows the breakdown of all the 16 patients in each cohort. And some of these patients genuinely didn't have biliary tract cancer. For instance, I think 10 to 15% of patients may have something masquerading as a cancer that looks like one on a scan, but is perhaps an inflammatory condition. So we learnt about how to integrate with our molecular tumour board in this very new area, and also some of the caveats, so false positives. Where do you have to, what are we worried about in terms of false positives? So worried about something called CHIP. So as we get older, our bone marrow can push out some DNA into the blood. Some of that DNA can have mutations that are in common with tumour DNA. Actually, an experienced molecular tumour board can call that out. And that was really very beneficial. Equally, you can find germline inherited variants in DNA that are not tumour-derived, but are in the germline inherited. And again, an experienced molecular tumour board will call that out. So, what I was very pleased about was that our genomic tumour board is really very dominated by lung cancer. It had to move into and be comfortable in biliary tract and pancreatic cancer, so it's now very much integrated into that service. I mean, I always come back to the patients. Is there a benefit at an individual patient level? And I think we could demonstrate already in this pilot study there was. So this is a patient with suspected pancreatic cancer who, in the process of invasive workup, ended up with life-threatening complications, pancreatitis and an ITU admission, and months of not being diagnosed, very frustrated, came into the programme, was found to be liquid biopsy positive. The genomic tumour board sanctioned that it was tumour-derived, and she was able to proceed and act onto treatment, access treatment, and did well, improved as a result. And another patient came from an external centre, an 83-year-old patient who felt that there was some age-related bias in how he was being managed. He had a lesion in the liver that was likely to be a biliary tract cancer. The first biopsy was inconclusive. A surveillance option was offered to him. He came into the study. He had a positive liquid biopsy. He then did proceed to a tissue biopsy and commenced treatment and did well on that. So then that provided the basis for a grant application. It was all quite fortuitous timing. We just completed that, and the SBRI NHS England launched a programme for projects to support faster or more efficient diagnosis or earlier detection. So based on our experience, we put in this proposal to add liquid biopsy to the diagnostic pathway in our Cancer Alliance across 6 NHS London hospitals, as indicated there. In stage 3 and 4, biliary tract and pancreatic cancer, if you ask me why we restricted it, the entry point for the innovation had to be that it was CE marked and FDA approved in that indication. And I'll show you the test that are using is indicated in that for that purpose. Equally, the majority of patients coming through this pathway do have stage 3 or 4 disease, aiming to assess 650 patients. So this isn't a research programme, this is an implementation project. And what we hope to show is that we can implement it and change the pathway, that we can reduce the need for repeated invasive investigations, that we have an impact on faster diagnosis as reflected in the wait times and some various other outputs. So in terms of the liquid biopsy we've chosen, it's the Guardant 360. This is FDA approved and validated for comprehensive molecular testing in all stage 3 and 4 cancers. It's a 74 gene panel. We chose it, we didn't stick with our own because it gives us more breadth. We could get the fusion testing, we could get the BRCA testing, and it had undergone, it fulfilled the criteria for entry into the trial. To the point earlier about is liquid biopsy validated for molecular profiling in advanced biliary tract cancer, I would say the answer is yes. Based on a validation study here of over 20,000 patients, hundreds of patients with biliary tract cancer, there was above 80% detection rate. So what did we do? We added it to the current pathway in parallel. So we haven't said we're replacing tissue biopsy. That's important. What does that look like? So what we find is the liquid biopsy pathway is a consistent 7 to 10 days. Actually, when we're looking at some of the current data, the median is around a 6-day turnaround time from blood test to result. And what we hope also to demonstrate is that whilst hopefully speeding up the pathway and getting through some of these bottlenecks, we also have this 2-for-1 efficiency. We're going to have to get a molecular result for these patients later anyway. Currently, that process, in my view, is time-consuming and cumbersome and can be delayed. Here, we're trying to push it right up into the diagnostic pathway through the liquid biopsy, sort of a 2-for-1 efficiency. On the point about the level of concordance, as all the concordance studies with liquid biopsies show a high level of concordance, and actually probably 15% of the time tissue misses something that liquid picks up and vice versa. So patient involvement and advocacy has been absolutely critical in, I think, the success of the programme to date in terms of actually framing our research question, getting it, co-writing the grant, getting it funded, and now monitoring and managing the programme and really keeping us on our toes, which I think has been phenomenal. We've defined 5 work packages. We've completed quite a lot of the first work package, the human factors implementation side. And as we think about NHS implementation, this is a bit new to me. I'm working with NIHR IVD based at Imperial, and they are really phenomenal about challenging us to what are the barriers to implementation? How does decision making happen? What are your stakeholders' views? How do we really make a success of this? And we're currently now in the recruitment, also the accrual phase. We're also embedding in health economics, again through IVD and another group, because in order for future NHS implementation, we know from my lung colleagues who are looking to implement liquid biopsies that we have to generate NHS level data for cost effectiveness. So I won't go through this in detail. How we're implementing it is through an NHS improvement methodology, PDSA, which is very iterative, and you keep going back to the sites, back to training, back to the pathway, and adjusting things as we go. One of the key outputs is to show a reduction in repeated investigation, that we've got power in that, but also an impact on the targets. In terms of some preliminary data for the first 50 patients, this isn't a study, so I can show you this. We see a median average age older than we do in any clinical trial, because this is a real-world project. About 25% of the patients have biliary tract cancer. That reflects the incidence, and about 45% are suspected stage 3. So of the first 50, we've had 42 with liquid biopsies. We see a 33 detected with ctDNA. That's a 76% detection rate, 70% in biliary tract cancer. And in terms of the molecular board, we define 4 levels of confidence of consistency with a diagnosis, not in isolation, taking into account symptoms, imaging, CA19-9, etc. And about half of the patients were diagnostic on their ctDNA with those criteria, and another sort of over 30% were consistent with. Diagnostic or consistent, and then another 30% were possibly consistent with, because some of the mutations might also be seen in other diseases. In terms of how patients were diagnosed, the majority have had both modalities, but just over 10% have had liquid biopsy alone. What I would, again, I've just come back to the patient cases. So this is a patient who was again struggling through the diagnostic pathway with multiple negative biopsies over 5 months. She came into the access program, was found to have a mutation. It was found to be MSI high. This is a really important finding in terms of therapy. The patient was in an older age bracket. This was considered diagnostic, and the patient had a liquid biopsy alone, and we have a separate research program where patients can consent to treatment, because it's not standard to be treated on liquid biopsy alone, but it's subject to the MDT agreement, treated on liquid biopsy alone in the Prevail Part 2 program, and was able to access immunotherapy. And similarly, another patient case presentation where, again, struggling to establish a diagnosis. On the liquid biopsy, we see a NRAS mutation. This was considered sort of next level down, consistent with a diagnosis. And again, the patient came for liquid biopsy alone treatment, consented in the Prevail Part 2 program, and accessed chemotherapy. So there are multiple potential challenges that we've learnt as we do this. So the potential for false positives, and being really vigilant for those, so that whether that's CHIP or inherited germline DNA, and the role of the molecular tumour board has been absolutely critical. I think there have been challenges in just implementing a single blood test that needs to be collected in a special tube and sent off, and the whole pathway around that. It's not been easy, but actually I think now all sites are really up and running well on that. I think Nothing in isolation, so we have to view all of the results together, so I don't think this is liquid biopsy trumping everything else. And I also think that the role of the MTB in integrating that into the care pathway has been really, really great to see, actually. And as we do this, and coming to some of the points made earlier, this really highlights everyday genomics in terms of the education of our workforce. And this is across gastroenterology and medical oncology and our nurse specialists and, and the patients. I think what we get feedback from our gastroenterologists is we actually really need something in stage 1 and 2, potentially operable patients, because actually sometimes that represents an even bigger challenge for needing tissue, which is increasingly required. So I think that is on the horizon. So just really to conclude, I think what we would really hope to demonstrate is benefits to the patients in terms of faster, safer diagnosis, a better patient experience, but also in terms of the NHS, again, a faster, more efficient pathway that is potentially scalable, that potentially addresses that variation across different regions for something that is really, I think, quite simple. And then just finally to say thank you to our incredible interdisciplinary team, gastroenterologists, molecular biologists, the genomic tumour boards, geneticists, our medical oncologists, our patient advocates, and our industry partners. And it has been, everybody has really come together, and I think there's huge enthusiasm therefore around the programme, which is why it's got as far as it has to date, and we hope to really complete middle of next year. So thank you for your attention. Thank you.